Greetings, everybody. Thanks for joining us for another edition of our Robert Wood Johnson Foundation Systems for Action Research in Progress webinar. For those of you who might be new, this is an event we have a couple times a month. It gives us a chance to get some early insight into research projects that are funded as part of the RWJF Systems for Action research program. In this program, we study innovative ways of helping medical, social, and public health delivery systems work better together, aligning those systems with the goal of improving health, and in particular, improving health equity for populations that experience inequities in health. For today's edition, as we periodically do during the year, we're going to feature some of our intramural research that we conduct through our University of Colorado-based group. In particular, we're going to hear from a couple of our PhD students who are working on several studies looking at the composition of multi-sector community health networks, and what we can learn about the structure and function of those networks and their role in helping to improve health equity. So this concept of inclusiveness is something that we've begun to think about how to apply in the context of looking at the structure of multi-sector networks. What sectors, what kind of organizations and sectors are included versus not included in those networks, and what implications does it have for the impact those networks can have on population health and well-being. So with that, we're going to hear from a trio of investigators on our intramural research team, all of whom are PhD students in our PhD program in health services research, and all of whom have been active collaborators with us on our Systems for Action intramural research team over the last year or two, or more in the case of at least one of our colleagues here. Elleni, Mehari, Kyla, Bauer, and Kelsey, Owsley. All of them have been leading analyses looking at this general topic of structure and composition of multi-sector networks with a slightly different spin, and we're going to hear from some emerging findings and research in progress in all three of these analyses. As we always do in these research in progress webinars, again, this is work in progress. And so one of the benefits as researchers and research teams that we have in presenting our work to you in a somewhat half-baked format is getting your feedback and getting your ideas about ways to take this research forward. And so we welcome your feedback. We actually expect your feedback in this section. We're banking on it. And so please be thinking about what comments, questions, words of advice you can give us along the way. We will reserve time during the hour to get to those questions and comments, and hopefully have a good discussion here. If you're with us on the webinar portion of this event, not just dialed in by phone, what you can do is use the Q&A button. Should be on the bottom center portion of your screen. You can click on that, type your question in there. That will help us just make sure that we're getting to everybody's questions and comments as we go forward. If you're with us just on the phone, we'll also try to make sure that we reach out to you as well. Please keep your if you're not already muted, I think everybody may already be muted, but if you're not muted, check that. Always good to check. It's good Zoom etiquette. Make sure you're muted to help us cut down on background noise during the webinar today. So with that, I think Kelsey Owsley is going to go first. As I mentioned, she's a PhD candidate in our HSR program here at the University of Colorado. Has been working with us for a couple of years now in the Systems for Action National Program Office. Some of her interests include hospital safety net systems of care, population health and public health delivery systems, and health disparities for aging populations. So, Kelsey, would you like to kick us off?
Thank you, Glenn. All right, you can see my screen? Okay, thanks.
Looks great.
All right, hi everyone. Again, I'm Kelsey Owsley, a PhD candidate at the Colorado School of Public Health. And my co-presenter and co-author on this study is Kyla Bauer, also a PhD student at the Colorado School of Public Health. And this project is evaluating inclusiveness in multi-sector community health networks, specifically looking at tribal organizations. I'd like to recognize our co-author, Dr. Glenn Mays, as well as this project was supported by the Robert Wood Johnson Foundation. So American Indian and Alaskan Native, or AIAM people, represent about 2% of the US population, with federally recognized tribes located in 34 states. However, about 75% of AIM people reside actually outside of tribal lands. And this graph shows the age-adjusted mortality rates for AIM populations in the dark blue compared to other races in the light blue. And as I'm sure you can see, AIM populations are disproportionately affected by public health amenable diseases and injuries. And these disparities contribute to a 5.5-year lower life expectancy relative to other racial groups. And unfortunately, we have seen these underlying health disparities place AIM populations at highest risk of serious illness for COVID-19, where AIM people are about 2.5 times more likely to die of COVID-19 compared to their white peers, and almost 4 times as likely to be hospitalized. Therefore, a robust public health system is needed in order to be able to address these persistent health disparities in AIM communities. And the Indian Health Service, or the IHS, is tasked with providing healthcare to AIM members of federally recognized tribes at no cost. And IHS either provides care directly or contracts with local tribes or tribal health organizations to operate health facilities. However, only about 3% of IHS funding is allocated to preventive health services, and about 6% of funding is devoted to mental and behavioral health services. And like I said earlier, the vast majority of AIN residents do live outside of tribal lands and are under the purview of the IHS, as well as non-tribal state and local public health agencies. And the responsibility to deliver public health services to communities that still live on tribal lands does primarily remain with tribes and tribal health organizations. And for some perspective, about 40% of tribal public health organizations do reside less than 25 miles from a non-tribal public health department. And in a recent capacity assessment conducted by the National Indian Health Board, tribal health organizations reported their top public health needs as funding support, training, as well as partnership support. And tribal organizations specified that partnerships are needed to promote cross-jurisdictional sharing of public health services and multi-sectoral efforts to be able to address social determinants of health. And as many, I'm sure on this webinar know, there is growing evidence that strong multi-sector networks of community organizations can reduce health risks and improve outcomes for underserved populations. However, the prevalence of tribal organization engagement in these networks is unknown. So in this study, we aim to fill that gap by understanding the variation of inclusion of tribal organizations in community health networks and the predictors of inclusion. And to do this, we used 2018 data from the National Longitudinal Survey of Public Health Systems, also known as NLSIS. And for those who don't know, NLSIS is a nationally representative survey of local public health departments that's administered every 2 years by the SRA, a National Program Office. And NLSIS collects information on 19 public health activities that are recommended by national guidelines and are really viewed as core activities for a functioning public health system. And activities include topics such as assessment, policy development, and evaluation activities. And for each activity, analysis asks, one, whether the activity was implemented in the community during the past 3 years, and if so, what was the network of organizations involved in activity implementation? And in 2018, a tribal organization was added as an organization choice. And our analysis includes a stratified random sample of local public health agencies that were surveyed with about a 70% response rate, as well as an additional cohort of non-random respondents that were surveyed upon the request of their respective state health departments. And this gave us a sample of 728 local public health systems. And to account for agencies that serve multiple counties, which is about 10% of our sample, we did disaggregate data to the county level, giving us a final sample size of 1,048 counties. And our findings were robust to excluding the non-random sample from the analysis. And we constructed 2 measures of tribal inclusion in community health networks. First, the extensive margins, which was measured as a binary indicator for whether tribal organizations participated in at least one of the 19 public health activities, and the intensive margins, which was measured as a proportion of activities with tribal organization participation out of the total number of activities implemented. And we also assessed the diversity in partnerships using tie strength, which was measured as the proportion of activities that were jointly contributed with other organizations. And we included a number of community characteristics, including AIN population size from the American Community Survey. And this measure was constructed using self-identifying AIN as either a single race or multiracial as a percent of the total county population. And we also included the presence of an AIN serving health facility within a region using the IHS facility tracker. And we included identifiers for whether the facility was operated by the IHS, a tribal organization, an urban Indian health program, or tribal-led facilities without IHS funding. And we defined region as a facility located in the same county or an adjacent county. We also calculated the distance to nearest reservation land using US Census Bureau data, and included a number of demographic and socioeconomic characteristics using the area health resources files. And we used 2-part regression models to estimate the predictors of tribal inclusion, with the first stage using a logistic regression model to estimate the extensive margins, and the second stage using a generalized linear model with a log length and gamma distribution to estimate the intensive margins. And then we created social network analysis visualizations to be able to evaluate the diversity in partnerships, with the dyads representing the tie strength between 2 sectors. So to jump into the findings, overall, we found that only 16% of counties reported any tribal organization involvement in community health networks. And when we examined by whether there was an AIN serving health facility located in the region, we found that if there was an AIN facility present, a little over 30% reported any tribal involvement, and tribal organizations were involved in about 10% of the implemented public health activities. Whereas if there is no AIN facility present, only about 9% reported any tribal involvement, and tribal organizations were involved in less than 2% of public health activities. And this figure shows involvement by activity type for the 165 counties with any tribal inclusion. We found that tribal organizations were most likely to participate in activities that included prioritizing and assessing community health needs, maintaining communications networks, investigating adverse health events, and developing a community health action plan. And this table shows the bottom activities for tribal participation. And notably, analyzing preventive health service utilization was one of the bottom activities. So this may be an area to improve tribal engagement especially considering the lack of IHS funding for preventive health services and the disparities in preventive health service utilization for AIN populations. And lab testing may be another key area for improvement, especially considering lab testing is such a critical component to address infectious disease outbreaks such as COVID-19. And this table presents the predicted probabilities from the two-part model. And these results, again, were adjusted by county level demographic and socioeconomic variables, including urbanicity, income, college attainment, and the number of physicians in a county. So we found that AIM population above 1% did increase the likelihood of tribal organization inclusion in both the extensive and intensive margins. So again, this indicates that population size did increase the likelihood of any participation, as well as the number of public health activities tribal organizations participated in once inclusion occurred. And for AIN serving health facilities that were present in the region, we found that only tribal-led facilities with contracts through the IHS were associated with an increase in any tribal inclusion. Whereas IHS-directed facilities, urban Indian health programs, and tribal-led facilities without IHS funding were not associated with tribal participation in community health networks. And we also found that proximity to tribal land was associated with an increase in any tribal inclusion, and also one of the main predictors of an increase in the number of activities with tribal inclusion. So now I will pass it off to Kyla to continue with our social network analysis results.
Just give me a quick second. Does that look good? Everyone can see? Okay. So as Kelsey mentioned, we're switching over to social network analysis. It's important to keep in mind that this is separate from the model. And so in order to improve interpretability, we did it at the public health jurisdiction level. You might notice the numbers are a little bit different for that reason. So it's not by county, it's by public health jurisdiction. The network on the left is the average community health network with tribal organization inclusion. And on the right are networks without tribal inclusion. For a quick breakdown, those dots represent 33 sectors and social services that are typically included in public health networks. And a big dot means that the dot is doing more public health activities on average. Any line between two dots means that those two dots are both participating in a public health activity together. So it doesn't mean that there's necessarily any kind of relationship going on there. It just means that they're both doing that same activity. And the more activities they're doing together, the thicker that line is. Going into a bit more detail on network characteristics, again, this is the network that includes tribal organizations. It includes all 33 sectors and social services that were included in our survey. The network density is very high at 94%. What this means is that out of all possible connections among those 33 dots, 94% of connections have been made. That's a lot of participation in public health activities in these communities. You can see by the size of the dot that there are some big players in these networks like local public health departments, hospital systems, state health departments, local government agencies, and community health centers that are doing a lot of public health activities, participating in them together. And on average, these networks are doing a good amount of those 19 essential public health activities, about 72% of them. And there's a very low betweenness measure, which just keep in mind, but I'm going to talk about that in a couple of slides. The most important part is that tribal organizations in these networks are participating in about 3% of the 19 essential activities and participated most often with local health departments, hospitals, local government agencies, community health centers, and K-12 schools. It's important to note that federal agencies and state health department is not on that list. In comparison, this is the average network that does not include tribal organizations. The network density is much lower Only about 40% of all possible connections are being made. There are a handful of sectors in social services along with tribal organizations that are just not being included. You can see that in those solo dots off to the right side. And I don't want to poo-poo these characteristics because these networks are still doing quite a bit at about 63% of the 19 essential public health activities. So it's lower, but still doing quite a lot. The big players are very similar in these networks, but overall there's just lower participation across the board happening. You can also see that betweenness measure again is much higher in this exclusive network than in the inclusive network that we saw previously, and I'm going to talk about that now. So when I say the word betweenness, I'm talking about access to joining the network. If an organization has a high betweenness measure, it means that they're playing a key role in connecting other organizations that are not as well connected. They are helping to bridge access to hard to reach organizations. So when a network on the whole has a higher betweenness measure on average, that means that there are players in the network that are hard to reach and someone is doing some heavy lifting to connect them. What we're seeing in networks that include tribal organizations on average is this decentralized way to access the network because so many sectors in social services are well connected among each other. And, you know, if you think about it, if you are a tribal organization wanting to connect to these inclusive networks, the easiest way to do that is through the local public health department or 12 other sectors or social services that will equally help you access joining that public health network. If they're too busy, the next best thing are 6 other sectors or social services. And then in contrast, if you're trying to join this average exclusive network in which tribal organizations are currently not involved, it's really important that you connect to that local health department. You can see the 144 is the betweenness measure of the local health department. That's really high. So they would be an important bridge to other sectors and social services in the network. But if they're too busy, the hospital system would be the next best choice. It wouldn't be as good, but it's the next best thing, and so on and so forth in this linear centralized way. So overall, what we're seeing is that tribal organizations are being included in networks that have this rather decentralized way to access the network, but there seems to be a barrier. They're not breaking into networks that have this linear centralized way to help join. Overall, some important limitations to consider from this study. The analysis data is self-reported from local public health departments, and so those perspectives are not from tribal public health officials. Future research, it would be really important to engage tribal stakeholders to get their perspective on how they're being included in community health networks. It has also been pointed out to us that the phrase tribal organization could mean either tribal government or AIAN serving organization, which are 2 different things, and we're hoping to clarify that in future surveys. To review from both of these, some key findings, again, the vast majority of public health networks are not reporting tribal organization inclusion. Even when AIAN serving health facilities are present, only about 1/3 of community health networks are including tribal organizations. Specifically, tribal-led IHS facilities do seem to be associated with an improvement in inclusion, but other types of IHS facilities are having no impact. Which is why it was important that we looked at these community health network characteristics. We did find that more diverse and denser networks were more likely to include tribal organizations. Something to keep in mind is that these community health networks change over time. And so it is possible that some networks are investing a lot more to try to be more inclusive, but they're at the early stages of development. Some suggestions on what can be done with these findings. It would always be helpful for local public health departments and their community partners to really be mindful of trying to include tribal organizations, especially if there's an IHS facility in the area. That's kind of the low-hanging fruit partnership that we would think of. Keeping in mind that inclusion does require investment in resources, and so there are grants that have started to dedicate funds to support cross-sector collaboration. So doing that specifically with tribal organizations could be really helpful. Also, tribal organizations tend to already have relationships with federal agencies and even sometimes state health departments in their area. It would be helpful if these agencies could help transition or support building relationships at a more local level, because what we're finding is that those local relationships are really important to try to get into or access local public health networks. And last, as mentioned before, even when tribal organizations are included, they're participating in about 3% of public health activities. Acknowledging that the IHS is severely and chronically underfunded, especially in preventive services, it would be really important to emphasize working with tribal organizations, especially on prevention activities. And that's, thank you so much for listening to that. That's all we have to share with you today. Let's see. Okay.
Fantastic. So I see we're getting some questions and some in the Q&A box and some chats as well. What I'm going to suggest is that we move ahead to our final panelist, Elleni Mehari, and then we'll open it up and have a general discussion of the questions. That's all right, just to make sure that we're good on time. So keep your questions coming in the chat box. We'll get to those in just a minute. But we're going to next pass it over to Elleni to talk a bit about her work also in the same theme about inclusiveness in multi-sector networks.
Awesome. Let me share my screen. Can everyone see that? Yes? Okay, perfect. Okay, so my name is Elleni Mehari. I'm a PhD student in the health services research at the Colorado School of Public Health under the Department of Health Systems, Management and Policy. And this project, I worked with Dr. Glenn Mays, and just an acknowledgement that Systems for Action is collaborated with the Robert Wood Johnson Foundation and the Colorado School of Public Health as well. So just to go over a brief outline of what I'm going to be discussing today, I'll go over the rationale for my research project, the research aim, go over some data and methods, the findings, and then focus a bit more on conclusions, implications, and future steps, future directions. So first I want to talk a bit about community health and specifically barriers to equitable outcomes in health, just in the context that we're aware that there are barriers to equitable outcomes in health for different groups of people. And when striving toward health equity, we consider preventable differences that are closely linked to social determinants of health. And I think many would define these preventable differences or recognize them as health disparities. And when I mention social determinants of health, that's just the conditions of our environments, our neighborhoods, and our communities. And these are things like housing and transportation, schools and workplaces, and social network composition as well. And communities differ in these domains, ranging from the affordability and quality of housing, different employment opportunities, different types of transportation systems and accessibility to them, and even things like local quality and availability of healthcare providers, as well as just other aspects of the environment. So I was really interested in local public health systems and looking at their role in improving community health, specifically in their efforts towards improving community health, particularly public health system capital, which I'll discuss a bit more, but generally that's the breadth and depth of multi-sector relationships of contributing organizations. And so here, not as focused necessarily on just looking at inequities in health outcomes, but whether inequities exist in the efforts that are directed toward achieving health equity across the US. And health action plans and initiatives can highlight which needs in a community are being prioritized, as well as where and how these efforts are being delivered. And this is especially true given that community health initiatives that are being implemented should be consistent with priorities that have previously been established from a community health needs assessment. And again, just thinking of that emphasis on health inequities and disparities and whether those are being addressed. And so community assets can be really important in building, leveraging, and even modifying this context of striving towards health equity, which does require a focused and sustained societal effort. And the literature has indicated that community-based and community-driven efforts are needed to alter the conditions such as environmental, socioeconomic, and even cultural conditions in ways that promote health equity. And so again, I was interested in examining how local public health systems fit within this larger framework. And so all of that leads to my research aim, which was to understand the relationship between public health system capital and the proportion of community health initiatives and action plans that are directed at reducing health inequities and disparities. So Kelsey touched on this briefly, but I'm going to go over it a little bit more. The National Longitudinal Survey of Public Health Systems, that's the primary data source that I used for this study, and I used the 2018 wave. So this is a stratified random sample of the country's largest local government public health agencies, and it's been surveyed in 1998, 2006, and then 2012, 14, 16, and 18. So every 2 years more recently. And I'm using the 2018 wave. And analysis collects information about the implementation of public health activities that have been identified as being important in protecting and improving population health, and just focuses on multi-sector engagement. And the survey respondent for the survey is the designated local public health authority, where the unit of analysis is the local public health delivery system. And then these local public health agencies were identified based on the National Association of County and City Health Officials, based off that definition. So it is based on these indicators of local public health system performance and can be used to capture the network of organizations that participate in each activity. So as Kelsey mentioned, the types of health activities and then which organizations contribute to delivering them. So for my analysis, I used a logistic regression model, and my primary predictor of interest was the composite score of local public health system capital. And this score was calculated using a combination of activity scope and then network density variables using cluster analysis. So those scores were previously calculated. And there are three main categories of capital for these public health systems. And this is an ordinal scope of limited, conventional, and comprehensive. So limited public health systems have the lowest density networks and the most narrow scope of activity implementation, so where they implement less than 50% of population health activities. Conventional systems still have a lower density network, but have a more moderate scope where they implement 50 to 75% of activities. And then comprehensive systems implement greater than 75% of activities. They have a dense network and also have central actors to coordinate the implementation of these activities. And so essentially, comprehensive public health systems implement the most public health activities and have the largest networks of organizations that participate. So I also wanted to capture multi-sector engagement. So these are the types of organizations that are involved in developing health initiatives and health action plans, and included many of the different sectors that could be related to social determinants of health, these sectors and determinants that I previously touched on a bit, as well as socioeconomic demographics within the communities, so percent non-white of a population, uninsured, percent poverty, population density, unemployment, and there was good overlap among these characteristics. So with that, my outcome is the proportion of community-driven health initiatives and action plans that are aimed at reducing health inequities and disparities. And I dichotomize this to be above or below 50% effort. So originally the question is asked on a more of a Likert scale. So of health initiatives and action plans that have been developed, was there any effort placed towards reducing health inequities or disparities, some effort, about half, most, or all of the effort. And so I just dichotomize this to make the interpretation a bit more meaningful, as there may not be much of a difference or much of an incremental change between some or about half. So I think this provides us with a little bit more meaningful information. And then I also want to note here that while there can be a distinction between in terminology between inequities versus disparities when discussing the health equity literature more broadly, the survey does ask the question as presented here, so where inequities and disparities are grouped together. And I think there could definitely be a conversation on whether these could be separated in the future, but I also think that it's acceptable for the purposes of the survey and this project, especially with consideration that there's one person responding for these surveys, and the definitions of these words can vary and are often used interchangeably. So I just wanted to make a note of that before moving forward. And so to jump into the results, so the probability of increased efforts towards health inequities and disparities was 15 percentage points higher in comprehensive public health systems compared to conventional and limited. And this was statistically significant. Each of these predictors were, and I think regarding effect size, while there may not be a defined threshold, 15 percentage point difference is a notable probability difference between these groups. And as far as multi-sector engagement, involvement of each of these sectors, so public health agencies, employer groups, support services for older adults, and transportation services, each of these sectors being involved in the development of health action plans and health initiatives, as opposed to if they weren't involved, were also significantly associated with increased probability of targeting efforts towards health equity, as well as rises in uninsured and non-white populations. And so I initially compared comprehensive systems individually compared to conventional and limited, since those were a bit more similar, but I also wanted to look at conventional and limited systems individually compared to comprehensive health systems. And so if you could recall that the public health systems are categorized in ordinal scope. And so with that, I expected to see the largest gap between comprehensive and limited systems. However, while the probability of conventional systems directing increased effort toward reducing health inequities and disparities was 18 percentage points lower than comprehensive systems, limited systems were only 12 percentage points lower. So we actually saw a greater gap between conventional and comprehensive systems, and we'll look at what that might mean in the following slides and what we can kind of garner from that. And I wanted to note here that this graph on the right is not a depiction over time. This is all 2018. It's a cross-sectional analysis. These points are both in comparison to comprehensive systems. And so I want to talk about the conclusions and implications kind of more hand in hand. So the first is that strongest public health systems were more likely to engage in equity-driven efforts. So these comprehensive systems with the greatest breadth and depth of multi-sector relationships were more likely to engage in these equity-driven efforts over both conventional and limited systems. And I think that speaks to the importance of prioritizing community partnerships and working towards health equity for the community and being able to provide the cross-collaboration support, as well as the resources to engage in these types of efforts. And keeping in mind too that feasibility and even just the ability to engage can be hindered by different constraints in the real world setting. So these comprehensive systems may be more aptly equipped to overcome challenges that could be presented in equity-driven work. Next, as I mentioned earlier, I expected to see conventional systems to be more comparable to comprehensive systems in their probability of increased effort towards health equity, but this wasn't the case. So limited systems have, or were more likely than conventional to target inequities and disparities, but they have the narrowest scope of recommended population health activities and have the lowest density networks of contributing organizations of all three categories. And so this scarcity may direct these systems to hone in on key areas within the community so that even if they do have a narrow scope, there's still targeted efforts within the activities that they are able to implement. And so the implication here is that limited systems may be more intentional with their distribution of resources. And maybe that's why we see a higher probability in limited systems than conventional, where conventional systems may try to address more areas of focus where inequities and disparities may not be as much of a concerted priority. And finally, community health initiatives and action plans can help identify if inequities and disparities are being addressed. And I want to mention here that Healthy People 2020, under the Office of Disease Prevention and Health Promotion, named 5 key social determinants of health that collectively serve to promote good health for all of us. And one is social and community context, and another is neighborhood and built environment. And so when we think not only of public health system capital, but how engagement of sectors like transportation services, like support for older adults and employers, all of these that were significantly associated with increased probabilities of engaging in equity-driven efforts, these are community-based sectors that could be leveraged to employ tangible strategies in improving population health. And I think how and when these strategies are employed may be a bit beyond the scope of this project, but I'm approaching this research as creating building blocks that can help connect all these different pieces of eventually and hopefully creating some type of meaningful change. And I think part of that is being able to see and identify a connection between tools like health action plans, like health initiatives, and opportunities within a community to act on the information or knowledge that's provided by these tools. And so thinking about future steps, again, that highlight and the importance of cross-sector relationships, but still needing to consider how this can be done within the constraints of resources, of personnel, and other challenges that may be faced in the real world. And I would like to look more into these limited systems, especially and how they operate, because I think that could provide more insight into the interplay of multi-sector relationships and connections given these lower density networks. And also looking at patterns and trends in communities. So, okay, we're collecting information on these efforts, but how do they actually affect outcomes? And in that way, I think it really becomes more of a full circle iterative process of evaluating both action, efforts, and outcomes collectively. And then I also think, social network analysis and looking at connectedness and influence of community organizations over time is really an important piece of future research. Because, like I said, this is a cross-sectional analysis, but mechanisms for change, I think especially regarding health equity, can be very complicated. And so cross-sectional analyses may not be ideal for capturing outcomes, but being able to look at these over time and being able to identify patterns or trends in communities, I think is really important, especially when trying to keep a focus on advancing health equity. And that's all I have for you today. Thank you for listening.
Fantastic. Thank you so much, Elleni. And thank you as well to Kelsey and Kyla for sharing with us your research in progress around looking at several different dimensions of inclusivity in multi-sector community networks working together to implement public health activities. So as promised, we are open for the question and discussion portion of our webinar. And we've already got some questions queued up. I'm just going to, I'm going to get to a couple of those. We'll get this kicked up. I'll start, and I'm just going to use first names in the interest of privacy in the Zoom world. But Kimberly gave us several good questions. Well, both I think referring back to the analysis looking at tribal organization engagement in multi-sector networks. First question is about the types of tribal organizations that we're studying here. She asked specifically about whether we're measuring tribal health director engagement, and or are we capturing 638 facility engagement in these networks. 638 facilities I know are a specific type of healthcare organization operated by tribes or tribal organizations. And so I think the answer is our survey doesn't really allow us to capture that level of detail, at least the current design of the survey. We're not able to distinguish among different types of tribal organizations or tribal organizations that serve tribal communities. But that is something that I think is on our radar as potential next steps for further work in this area. Kelsey or Kyla, anything else you want to add on that front?
I will add that the 638 facilities is what we consider tribal-led IHS facilities. And so we did see that those are the facilities that are associated with an increase in tribal engagement. So I do believe that the respondents taking the survey consider tribal organizations to be the 638 facilities.
Yeah. At least communities where 638 facilities are located are more likely to report tribal organization engagement in the networks. Is that yeah, good point. Thank you, Kimberly, for that question. And again, it is on our radar to in subsequent work to see if we can capture more granular data about the types of tribal organizations that may or may not be engaged in these networks. It is an important area for future work. Let's see. So other questions that are coming in through the Q&A box. Again, feel free to add your questions to that box. Jason asked, again, I think this question refers back to the tribal organization engagement analysis. How was the social network analysis validated internally or externally? Is there a paper on this study? Good questions, Jason. I might give a couple of thoughts and then we'll ask our panelists as well. So the instrument that we use, the National Longitudinal Survey of Public Health Systems, did have a battery of validation work that we conducted during the process of developing that instrument back in the 1990s when this study was developed with CDC support. So the overall instrument has been tested for measurement validity, several different ways, both test, retest validity, as well as inter-rater reliability validity testing. But I would say this category about measuring tribal organization engagement was a category we added to the survey later on in the process, and we have not done any validation specifically related to what we're measuring in terms of tribal organization engagement. That would be probably a good idea for us to examine in subsequent work. In particular, as was noted, I think by Kelsey and Kyla, our respondent to the survey, the person filling out the survey about these networks and who's engaged, is the city or county public health agency director, not a tribal organization representative. And so that is an open question: is would we get different answers, different measures of tribal organization engagement if we're actually talking to stakeholders who are embedded in these kinds of tribal organizations? That's an open question that I think we definitely want to investigate in subsequent work. But let me ask Kelsey and Kyla, any other thoughts on that question?
Thank you. Covered it all.
Fantastic.
Working on a oh, go ahead.
Yeah. Oh, yeah. Publication. Go ahead, Kyla.
We're working on the publication, but it will just be descriptive at this point. So, yeah.
Yeah, I've seen several preliminary drafts coming along nicely. But this is work in progress, not yet published, Jason, but but soon it's coming. Question from Gemma: were there any Indigenous researchers working on the Tribal Health Disparity Project? And additionally, what do you think could be done to improve the cultural competency of health organizations in relationship to Indigenous populations? Two great questions. I'll jump in and say, in terms of the first part of that, we did consult with several subject matter experts when we added the element to the survey to track tribal organization engagement in the survey, in particular with colleagues from the National Indian Health Board, from the California Rural Indian Health Board, as well as some colleagues from actually University of Victoria in British Columbia, who do a lot of work with First Nations in Canada. That was the group that those collaborators really piqued our interest in being able to examine tribal organization engagement, and helped consult with us in terms of adding the survey elements to our survey to be able to measure this. We do recognize it's really important for us to engage with Indigenous researchers and others who've got much deeper expertise in working with tribal populations than certainly our team does. We're fortunate to have on our campus at University of Colorado a very well-known Indigenous Health Research Center called CIAN, the Center for American Indian and Alaskan Native Health, led by Sparrow Manson himself, a very well-known Native American researcher on our campus right here in our School of Public Health. So along with other investigators at CIAN, we have consulted with that group and have plans for further work with Spiro and his group, and so that's definitely part of our plans. Does that, Kelsey and Kyla, anything else to add on that front?
I would just add, for cultural competency, that wasn't a part of our study, but looking at reports that have come out from the National Indian Health Board, their main goal is to have partnerships. And I think the relationship is really important, to have tribal-led efforts within the community to ensure cultural competency. And so I think that word partnership is really, really important, that at least the National Indian Health Board is really emphasizing.
Fantastic. Yeah. And one more thing I meant to mention, I'm on a national advisory group for NACHO, the National Association of County and City Health Officials, around just the advisory group where generally we discuss research priorities around what we need to learn about, especially local public health systems going forward. The National Indian Health Board is also on that committee, along with public health experts from several tribes around the country, including the Eastern Band of Cherokee. So that's one other forum where I know we are discussing these issues around what we need to learn about cultural competency and in engaging tribal organizations in multi-sector public health work. So stay tuned. I think there's more work, more to be said on that front. Okay, I need to pick up pace because these are great questions, but they're coming in fast. Beth asks, is there a plan to repeat the study related to IHS or AIAM population, especially now that analysis is added at tribal organizations category? And I think I can say definitively, yes, this is a survey now that we do on a 2-year cycle. And we're eager to repeat this analysis with additional ways, particularly a post-pandemic wave of data to look at change over time. And I know Kelsey and Kyla, you both have probably thought more specifically about what you might do with longitudinal data, but other thoughts there?
I don't have other thoughts at this point. Go ahead, Kelsey.
I think there's another question too about looking at outcomes. And I think especially once we get the longitudinal data and more specific granular tribal organization data, that'll be a really interesting thing to see. One, how it's changing over time since COVID-19, of course, once we get the survey data, but then also, once we have longitudinal data, connect it to outcomes and see how these how inclusion actually could possibly impact health of Indigenous communities.
Absolutely. Yeah, and that's a great segue into Yolanda's question about do we have analysis looking at the impact of tribal organization engagement in these networks? And not yet, but I think definitely with longitudinal data, we can capitalize on both cross-sectional and longitudinal variation in tribal engagement to then be able to isolate the impact of that type of inclusiveness. So thank you for that, Yolanda. It's on our radar and to do and as we move this work forward. And certainly invite anybody else who might want to make use of our data to add to this research stream. Always love to have more partners in this work. Okay. Beth also asked, how do we define strongest public health systems? Elleni, you want to take that on? Or?
Yeah, so for these and for my study, these comprehensive systems that we identify as the strongest are those ones that implement the most population health activity. So that was greater than 75% compared to other public health systems that, implement fewer, as well as the strength in terms of the breadth and depth of these multi-sector relationships within a community. And so the strengths of those ties, as well as the number of population health activities that are implemented, are how we defined that.
Fantastic. Yeah, and that's a typology we've been using for about a decade now. Be glad to share more information on that. Was the result of an earlier study that Robert Wood Johnson Foundation funded us to actually develop a typology of multi-sector public health networks and systems. And so we've used that over time in a variety of studies to show, both studies are looking at both what drives change in networks and also the impact of change in networks on health, important health and economic outcomes. Milbank Quarterly, I think in 2010 was one of our publications on that typology. Okay. Let's see. Kimberly gives us an interesting equation about inequities / disparities equal social determinants of health. Any thoughts on that, Elleni, on that that equality, that relationship?
I think they're definitely related. I think when we think of social determinants of health, it's thinking of those different sectors, like housing, education, financial, but then looking at inequities and disparities are the differences amongst groups against those different determinants. So where different groups of people have different outcomes or are placed in different conditions within those social determinants that are preventable or unjust in some way. And so there may be differences that naturally arise between groups, but then when it becomes something that's, like I said, that's something that could be preventable, then I think we think more of inequities that may exist within a community along that continuum of all these different determinants of health. I don't know if you have more to add on that, Glenn.
No, I think well said. Well said. I know we're getting close to our time here. Let's see if we can squeeze in a couple more. We have an anonymous question to ask about: is there a shorter version of our instrument that could be more feasible for use implementation in settings that may not be able to get through our full 20 item survey instrument? Unfortunately, not. We don't have something like that developed yet. That's something that is a great idea and something that could potentially be done. I think if anybody's got an interest in working with us and looking at a short form kind of screening version of our survey, that would be fantastic. I will say that the instrument we do use is actually already a short form tool that was derived from a much larger instrument we originally started work with back in the CDC support back in the 1990s. The original instrument had 84 items. believe it or not. We're down to a 20-item survey. It's still not trivial to get through, given the sub-questions and the network data we capture. It's a 30 to 45 minute average response time instrument. So we recognize that we should be looking at some lower burden ways of measuring some of these constructs. Thank you for that idea. Let's see. Yolanda, give us another question. Let's see if we can get one more question in. Asked about the primary driver of public health systems' decision to prioritize health inequities and disparities work. Is it funding? Is it some community intention or community-based driver? Any thoughts on that, Elleni?
I think that's a really interesting question, and one that I am definitely excited to delve into more. I think funding is often, if not always, a consideration when thinking about this type of work. But it is really interesting to me that limited public health systems address these inequities and disparities more than conventional systems. And I think that does, or it could potentially point to greater prioritization in intention and targeted efforts towards addressing health equity, even with fewer resources, whether that be, I think I mentioned like personnel, or whether that be funding or financial constraints. And so that's definitely was an interesting finding, and one that I want to explore more, because that, to me, that does suggest that funding may not be the primary driver, and if not, then what is? And it may not be just one thing. There could be a huge interplay of many different factors.
Fantastic. Thank you so much. We are out of time for today's webinar. Thank you. Thanks to our panelists, Kelsey, Kyla, and Elleni. Great work, research in progress. Stay tuned for more work in these research streams, as well as other studies that will be featured. We do this about every 2 weeks. Get on our website at systemsforaction.org. You can sign up for this webinar series, our newsletters, lots of other exciting things happen. Thanks so much to the Robert Wood Johnson Foundation, and to all of our colleagues out there. Stay safe, and we'll see you all soon. So long.